All right. Well, thanks everyone for regrouping. We probably still will have a few people coming in, but we'll get started here. So this is I remember this from last year at the CLL Live in Niagara. This is a really fun part of the day. And so I'm really looking forward to this kind of question and answer period so it'll be myself, Dr. Villa, who you've already met, and I'd like to introduce Dr. David Scott. So Dr. Scott is the clinical director of the Center for Lymphoid Cancer Research Center. He's a professor in the Faculty of Medicine at the University of British Columbia. He's a colleague of ours within the lymphoma tumor group at BC Cancer at our Vancouver Center here. And, he has a practice treating CLL patients and lymphoma patients. He's also a clinician scientist and is going to give us a discussion about research in CLL at the next talk. And I'll give you more of his research bio at that time. So yeah, happy to have you on the panel. And I think Raymond will be introducing the questions.
Thank you, Elena. We got a lot of questions. And so we've had to make a selection, and some we've glommed together. So you may not recognize your question or may not even be asked, but unfortunately there's time limitations. One thing I want to mention before we get to the questions is that there will be videos of the presentations and of the panel on our website in a month, maybe, something like that. So you'll be able to watch these again, and I know there's a lot of information, and it's sometimes useful to go back over it and look at the video, and you download the PDF and really study it a bit more so it comes in. Okay, great. The first question is kind of a number of questions that I put together. It's a little bit incoherent, but I think you'll understand where I'm going. And it's a combination of what lymphocyte count is used to determine the treatment start. But if there's a decrease, does that mean if my lymphocyte count decreases? Does that mean more time until treatment? And what about the other factors, that other symptoms I have, and how did that figure in? And how do you distinguish between whether my symptom is coming from my CLL or from something else? So that is sort of a combination of, I don't know who wants to start on that, but
I'm happy to start, and then others will add in. So the lymphocyte count is one of many factors that we consider, and the traditional thinking is that one of the markers for starting to talk about or initiating treatment is a doubling of the lymphocyte count within 6 months. And we're not talking about it going from 5 to 10, we're more thinking about it going from 50 to 100 or more. And then it factors in with all of the other things like, is your hemoglobin going down and is it low, platelets, et cetera, et cetera. So it's one of the factors we consider. We also know that lymphocyte counts go up and down with stress, infection, and other things like that. So I like to actually repeat it, particularly if somebody talks about having had a recent infection or a vaccination or something like that. So it's one of many factors in there. But I think it is important to think about. With other sorts of lymphoma and leukemias, we know that the cells, if that can be larger and can clog up vessels and things like that, but that's not a concern for CLL. And so I have some of my patients that I'm following who have counts in the hundreds and have absolutely no symptoms. So it's one of many factors. But there's not, for me, a threshold that I say, if it's above this number, we have to start treatment. It's more about a trend and putting it into context.
Yeah, thanks. I completely agree, and just want to pick up on the concept of trend. And I often talk about that with patients, that a one-off blood count doesn't really mean anything. It's all about the trend. Which direction is this heading in? And because we know lymphocytes can go up and down, as Dr. Scott said, so it's really about seeing over a few different blood tests, often over a number of months, what trend is happening. So yeah, I think that's an important discussion, especially if you see something that looks concerning. It's very possible it's just a one-off, and we need to repeat it to see what the trend is.
I would add that when a person is heading towards the need for therapy, that rising lymphocyte count will usually come in a package with other things, it's going to come in a package with other changes in blood work, symptoms, and so it's very rare that it's just an isolated finding, but it can be. The other piece of the question was, how do you distinguish CLL symptoms from something else?
Symptoms of other problems.
Well, it's hard because we talked about how CLL is a disease that is often associated with infections. And sometimes you can have false alarm. You know, the classic example is during flu season. There's always 1 or 2 phone calls of people who get the flu and their neck nodes swell and their blood work changes and they call in a panic. The flu passes and things go back to normal. So you do need to rule out underlying infection, although, as I said, truly progressive CLL, it's pretty obvious that the fevers are from CLL and not from an infection, but you have to do the workup.
The symptom that I find the hardest to work out is fatigue and lethargy. That's really challenging because sometimes it's related to the CLL and sometimes it's not. So I sort of, that's a symptom that I try and put together with other things to sort of use as a trigger for starting treatment. And I do warn some of my patients that will treat the CLL and it may come nicely under control and the fatigue may or may not go away. So we have to sort of, temper that discussion. And it's very interesting. Previously, when we were using chemotherapy, it was really difficult because people would become very fatigued during the treatment and then it would take months to recover. And then they'd kind of go, I actually don't know whether I'm less fatigued now than I was before because there's been all of that intervening time as well. Whereas now with the treatments that we're using now, sometimes people come back after a couple of weeks and they say, my fatigue is much better. And you kind of go, okay, so it was contributing. But things are changing with the new treatments.
Okay, we have a question that's kind of related here is, what is accelerated CLL or SLL? And why is this designation considered controversial? And what are the implications for prognosis and treatment?
That's a great question. It's controversial because we don't really understand it. So we do know that there's certain cases where patients have it's generally associated with a more faster growing form of CLL, and the cells look a little bit different under the microscope and sort of behave a little bit differently in terms of what we see in the blood counts. And so there's been various ways of calling it, and in some classifications it was labeled as this accelerated CLL. But really, it's not actually an official term in our current classification. And we treat it similarly as we would to other CLL. So it's the same concept of you treat it when you need treatment based on those IWCLL criteria and the things we were just talking about. And we use the same drugs. All of the same treatments apply, and we do the same types of prognostic testing, the same kinds of mutation screens, that sort of thing.
Okay.
But maybe for the audience, how do you distinguish accelerated CLL from a Richter?
Yes, good question. Well, yeah, so Dr. Villa talked about Richter transformation a little bit in his talk. I didn't touch on it in my talk because it's a very challenging topic. So that is when the CLL actually switches into an aggressive kind of lymphoma, generally something called diffuse large B-cell lymphoma. Rarely it can switch into Hodgkin lymphoma. And so that is usually diagnosed on a biopsy, and the biopsy looks very different. So those kinds of lymphoma look different than CLL. The problem where it gets tricky is that you often can have a mix of cells in one biopsy specimen. So you'll have CLL cells, you'll have bigger, ugly CLL cells that might look like this accelerated version, and then you'll have lymphoma cells, which look different. And so sometimes there is this spectrum, but generally for Richter transformation, we do need to see kind of tissue proof of lymphoma, a different kind of lymphoma, aggressive lymphoma. Do you have anything further to add?
Okay. Thank you. Next question. Is it possible for a COVID infection to increase or worsen CLL symptoms? But I would say CLL or CLL symptoms. I'll edit the question just to throw you guys for a loop. If you can, if there's no answer, that's fine too.
Yes. So I just gave the example of the patient with the flu, and I think during COVID, we all had patients with CLL who got a COVID infection, and it definitely triggered an immune reaction, as COVID does, or as any virus does. And so, yeah, we saw changes in blood work. Some patients had very odd changes in their blood work with neutropenia, low neutrophil counts and low platelet counts, and and swollen nodes. And once that passed, they came back to more or less the same level. Can COVID trigger progression of CLL? Can COVID trigger a cancer? I don't know. I think we all had cases who came in with progressive disease after a COVID infection. Is there a true cause effect? I don't know. It's a virus that we just don't understand fully just because it's so new. But we don't think of COVID as an oncogenic virus like we think of Epstein-Barr virus or hepatitis B virus. But I think the short answer is we don't know because this is all very new.
Okay, great. Thank you. You did a good job there. Excellent. For those who are in the watch and wait phase, do you recommend their care be overseen by their GP or an oncologist?
That's a great question. I think that, so in New Zealand, which is where I'm from, we had very limited hematology oncology resources, and we had a lot of patients being referred through with either monoclonal B-cell lymphocytosis, which sometimes and sometimes doesn't go on to be CLL, and patients who are in a watch and wait phase. And we had to think about capacity. And so the policy was to write extremely clear instructions to the family doctor about what blood tests to do, what to be looking for, and all of the triggers to send the patient immediately back to a hematologist or an oncologist to resume care. And I think that actually is a safe practice, and it depends on your relationship and how comfortable you feel with your family doctor. So there are some people who actually find it a little bit stressful to be coming into our cancer care and treating environment and prefer to be with their family doctor, and some people who feel very strongly that they'd like to be under an oncologist's care. And in many cases, I end up sharing care, that I'm seeing somebody every year, and they're seeing their family doctor in between times. So I don't think that there's a right answer to that question.
I would add that it depends, and again, it varies from patient to patient. Most of the time when you're seeing a new CLL consult, you have, not always, but most of the time, people have had a number of blood counts over the years. And so you can kind of tell when their lymphocyte count started to rise. And you can kind of tell what the behavior of the CLL has been up until that point. And you can kind of draw a line through that. And so a patient with a low lymphocyte count, completely normal blood counts, no lymph nodes on exam, normal spleen, no infections, where there's kind of already some amount of data suggesting that their disease is not picking up pace rapidly, that patient is completely appropriate for follow-up by the family physician with clear instructions. In my consultation note, I literally copy-paste the IWCLL indications for treatment. We're happy to see them if there's questions. And that allows the oncologist to deal with the patients who are doing the venetoclax ramp-up, doing, the third-line pirtobrutinib, where you really need oncologist brain power and time.
Okay. So it really depends also on your transmitting the criteria clearly, so the GP knows what to. Because that was my question: was I'm seeing my GP. How do I know that he knows what to look for? So I guess that's an important aspect to make sure the oncologist communicates that to the GP. Go ahead.
And I think that's also where patient education is key as well, right?
Yeah.
We try to give information. You've seen the tables down below. Some of the booklets in our clinic, we have some of the Lymphoma Canada booklets, for example. So we try to give those, try to empower patients to also be aware so that it can be sort of shared care with the physicians. Even with your hematologist, that's important, because we might say the disease is very slow, we'll see you in a year, but then of course that doesn't mean that nothing can happen in the year. If something does happen and you're aware of the signs to look for, then we want you to reach out and want to see you sooner. So yeah, that also points to the importance of what you guys are doing here today.
Monitoring your own disease and symptoms, essentially.
Yeah.
When should prognostic testing first be done? But the real question here is, why would testing not be done on a stage 0 asymptomatic patient? He's talking FISH, TP53, IGHV. And he said newly diagnosed patients who's at stage 0.
Yeah, I mean, that's a great question. And I think that the important thing about those prognostic tests generally is that we're using them to guide our treatment. And with many of them, they change over time. So if you do it at the time somebody's diagnosed, that doesn't necessarily mean that the disease is going to look like that at the time they need treatment. The one exception to that is IGHV testing and looking for mutation versus not, because that's stable over the course of the disease. But when we first meet someone, particularly if they've got very little disease, we actually don't know whether they're ever going to require treatment. So I tend to wait until I think that in the next 3 to 6 months that we're going to be starting treatment. And with the first time I do the testing, I do everything. I don't need to do the IGHV testing again for that patient. But when they start each line of therapy, I'm going to repeat the FISH and the mutation testing for TP53 unless it's already been seen before. Yeah. Because if it's been seen on one occasion, it doesn't go away. And so I know what I'm dealing with. So that's my practice, is to wait until I'm fairly confident that the person is going to require treatment, because I want to do tests that are going to change how I look after the patient, not just to put people through a test and anxiety related to that.
To give people reassurance, it's actually a trick question on the medical examinations. You throw a case of a patient with newly diagnosed CLL who has absolutely zero indication for treatment and a low lymphocyte count, and for whatever reason, a FISH was done and there's a 17p deletion or a TP53 mutation, and the question is always, what do you do? And the temptation is to recommend treatment, and the answer is always, doesn't change your management. Repeat the test when you need it.
My question about this is, I'm hitchhiking on this question, is how much faith should we as patients put into our prognostic markers? I mean, I've heard cases of people saying, somebody writes in the forum, says, I got 17p deletion, that's the end of the world, and you get an answer saying, well, I've been, for 10 years with untreated CLL, and I got 17p, So, I understand for a doctor, you want to get a sense of what kind of patient you're dealing with, but us as patients, what we're concerned about is what is my future looking like? How should we think about these prognostic markers? How much faith maybe faith is the wrong word, but how much weight should we put on that as we think about our own conditions?
I think that's a great question, and it points to that all this talk of prognostic markers, it's all trying to guess what's going to happen in the future. And some of them might be a little bit better at helping us guess, some not. And as Dr. Scott said, they change over time too, as our science gets better and we learn more. And what we've seen recently, as new treatments come in, newer prognostic markers are more important, and other ones become less important. So this is constantly a moving target. It is a bit of a guess. And I always tell patients, actually, time is probably the best prognostic marker. So in the example that you gave of someone who's maybe newly diagnosed, but we can actually look back on blood work for 10 years and see that their lymphocyte count slowly started to go up over the last, say, 5 to 10 years. That is, to me, the best prognostic marker. You've been pretty stable for 10 years with, very little change in your lymphocyte count. I can predict that if this is going to continue like this for probably your lifetime, you probably have good risk, low risk CLL just based on time. So I think for an individual person, it's how it is time. It's that trend that we talked about. And then, yes, these prognostic markers do help, and they do help guide treatment. So for that, it is useful, but completely agree. It's a bit of a guessing game. And really how your body and how your CLL is over time is probably the best indicator.
I agree. Yeah, and can't remember this was really answered in the presentations, but it's about the IGHV mutated status, because that's also prognostic. So they fished that out of here. That it was more important in chemotherapy than with the newer targeted treatments, because unmutated predicted poor response. But what about now? How much importance should we give to it?
I'm going to say something and then Alina's going to correct me.
It's always interesting when we have a bit of...
So I mean, with TP53, but also with IGHV status, now with the more modern treatments, it's a factor that slightly pushes me in suggesting one treatment over another, but not nearly as strongly as it did for chemotherapy versus these newer agents. So I think that was really important when you were choosing between chemotherapy and, at that time, ibrutinib. But I think now it's much more subtle. So I think that there's a little bit of evidence that would push you slightly in the direction of then venetoclax obinutuzumab if you're unmutated versus BTK, and I'd go slightly the other way if you're TP53 mutated. But I think it's so subtle now that it would be, I'd take everything else into account more than I would that. And now Alina can tell me what the latest thing shows.
Oh, no, I agree. The mutational status, this unmutated, mutated, absolutely. That was really key when we were giving chemotherapy. I kind of alluded to that I didn't show, but there's quite good data that patients with mutated CLL, which is good risk CLL, can do very well with chemoimmunotherapy. And that's kind of why in Canada in particular, we still had chemoimmunotherapy and still do as part of our treatment algorithms for patients with that mutated CLL. And then when the newer drugs first came in, they were actually only approved in patients. First, it was with deletion 17p. Then it was also with patients with unmutated IGHV. Then it was just in older patients. But now we're kind of at a point where it's much more broadly available. And so these prognostic markers are maybe less relevant. Also, we didn't show a lot of survival curves, but when we show survival curves, we're often trying to show differences in how patients do. And with chemotherapy, the curves were very different if you had mutated or unmutated. But now with all the new drugs, these curves are becoming much more closer together. And we as clinicians and researchers, we do look at them closely and argue about them and say, oh yeah, actually with this particular combination, it's slightly better if you're mutated or if you're unmutated. But it's a bit of a wash. In the end, they're basically similar.
So I think it's important to distinguish a prognostic factor from a predictive factor because it's two separate things, and I just want to make this clear. So a prognostic factor just tells you or estimates prognosis regardless of what you do. A predictive factor predicts for response to a therapy. So here we are talking about prognostic factors. So here we're not saying that if you have unmutated CLL, you do better with AVO or you do better with I plus V. That's not what we're saying. Because if you look at all of these studies, and they always have the mutated population and the unmutated population, and the unmutated population, they respond to the novel therapies, but their overall outcomes are worse compared to the mutated patients. And so this is what you're hearing from my colleagues, is unmutated still is associated with a worse prognosis, but when it comes to these novel therapies, it's hard to tell if that factor predicts for a better response, which in turn leads us to recommend one treatment or another. That piece is very difficult to tease out.
So basically, you're all saying prediction is very difficult, especially about the future. That question, is CLL inheritable? Is it preventable?
I can start. So great question about inheritable. That's a very common question that people have. So we know, we know that CLL is more common in certain groups and certain ethnicities. So actually in kind of Western European, Caucasian ethnicities, CLL is more common. We don't really understand why. There's been large studies looking for particular genes that might be passed down in patients. And, why is this? And it's not like one specific gene has been found, like maybe in breast cancer, for example, for some hereditary forms. There are some patterns and some genes that maybe are a little more common in families who have a couple of people with CLL, but there's not like one standout that we could test for and say, okay, yeah, you're at risk of getting CLL. We know that in families, people, there is a slightly higher risk of CLL in first-degree relatives of patients with CLL. And again, it might be due to these factors that something might be being passed down, but it also might be because the family's more aware of it. People are getting, as soon as they notice a lymph node, they might go to the doctor sooner because their mom had CLL and they've heard of this, things like that. So it's been very hard to tease out. And in general, I would say it's not inheritable, although there's a slight increased risk in first-degree family members. All this to say, there's nothing that we would recommend that family members get done in terms of screening. They don't have to get blood tests. They don't have to, have a CT scan to look for lymph nodes. It would just be to have awareness, and if there was something abnormal, to have that investigated at that time. Agree?
And about it being whether it's preventable.
Oh,
yeah. So you think about, for example, in the solid tumor world, we believe that less than 10% of tumors have like a clear gene driving the show. For example, BRCA1, BRCA2 with hereditary breast ovarian cancer, and that type of gene has not been identified in CLL. So it's not that. What causes CLL? The truth is nobody knows. We know what causes that B cell to all of a sudden flip into monoclonal B cell lymphocytosis, and what in turn causes that monoclonal B cell lymphocytosis to flip into CLL, nobody knows. And the favorite doctor answer to that question is it's multifactorial. It's a little bit of everything. And I think that's true for cancer in general. I think genetics play a piece in that, but lifestyle, environment, stress, blah, 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 like collectively, exposures, all of those things collectively lead to a cell turning cancerous. So, we all like to have black and white explanations. We all love our yes, no, 1-0, but that's not the way cancer works. And so is CLL preventable? I don't know, because by the time we see CLL, there's been all this other action leading to the CLL.
I agree with all of that. The explanation I give, and it's not absolutely 100% accurate, is that CLL and the other B-cell lymphoid cancers are a side effect of our very clever immune system. And during the process of developing cells that can react to all sorts of different proteins and viruses and bacteria, there are processes where the body deliberately goes in and attacks and rearranges DNA as part of that process. And those enzymes can go off target and hit other genes and contribute to CLL and other lymphomas. And we know now that some of those very early hits to the genetic system actually occurred decades before the CLL. So they can occur in your 20s and 30s. And we don't think that it's any specific thing that you've been exposed to in most cases. It's a clever, it's a side effect of our clever immune system. So, 100 years ago, where we had no vaccines, some vaccines, no antibiotics, the biggest threat that we had was infection and other diseases. So our immune system was very, very useful. Now, where people are living to their 70s, 80s, 90s, we're starting to see the dark side of this very clever immune system in some people.
Much better.
So that's a different answer. It may not be correct, but...
But it's a very interesting and complementary series of answers. So great teamwork, guys. Now, this is a question that's going to be answered, I think, partly in the What You Can Do session, the last session. But I thought I'd throw it to you anyways to see if you have a particular angle on it, is what can we do to improve our immune system? So it's in the, living better with your situation. Any thoughts? Or we do have a presentation partly dealing with that.
you can do what you can control. Okay, I showed you that one of my first slides that had kind of the picture of the immune system and kind of the whole family tree of immune system cells. It's complicated. So what can you do? All the stuff that everybody knows that they should be doing, but nobody does it. You should be sleeping 8 hours. You should be exercising every day. You should all of that stuff. People ask all the time about supplements. People ask all the time about intermittent fasting and ozonated water and hyperbaric oxygen and weird stuff that they buy on Amazon. And I don't know. And this is why it's so frustrating for patients when we tell them to exercise and eat healthy and not drink too much. Because there's really not much more that you can do. You should advocate for yourself. You should be educated about your CLL. That's not going to make your CLL behave one way or another. But there's so much you can do, and there's so much that you can control.
Mandatory push-ups before lunch.
Add to that, yeah. So I agree with what you've said. I think from an immune system point of view, I know that there's, as we've heard, that CLL patients are immunosuppressed. There is an increased risk of infection, and I understand that that's a real fear and concern of most CLL patients. The things that we talk to patients about in general, staying healthy, the things you mentioned, vaccinations are important, and we generally recommend yearly flu vaccines, keeping up with COVID-19 boosters, pneumonia. So generally after 65, pneumonia vaccines. You can consider shingles vaccines, and there's now a new RSV vaccine. Those are sort of the main vaccines I usually talk about with patients. There is something that many of you are probably aware of. So in certain situations, we know that patients with CLL, their immunoglobulin, which means antibody levels, are low, and we can test for that. And if they're low and somebody's having recurrent infections, and we usually think of that as at least 3 infections that have required antibiotics in 1 year, or a very severe infection, like a severe pneumonia that's been hospitalized requiring IV antibiotics, or a cellulitis, so skin infection that's not getting better. In those cases, we can consider there's actually a blood product that replaces those antibodies, those immunoglobulins. It's called intravenous immunoglobulin, IVIG, or we now have a subcutaneous version that goes under the skin, subcutaneous immunoglobulin, we call it SCIG. So probably a number of people are on IVIG or SCIG. That is something that we can do. It's one small piece that feels we can control a bit, but it's not black or white either. The evidence and the studies for that are not that great. It feels good because we're doing something about it. The immunoglobulin levels will go up, and some people will notice a change in their infections for sure, but not always. So that's a bit of a balance. I would say those 2 things are the most kind of active things people can do. And then being aware, certainly during the COVID-19 pandemic, was wearing masks, being careful not to be around people who are sick. In general, day to day, we don't necessarily need to unless you are sick or there's people around you who are sick. But those are just some of the other factors.
Great. Excellent answer. Thank you. Bone marrow transplant. What are the indications? Let's just say, is there still a role for bone marrow transplant in CSL? And if so, what would it be? Because it used to be a go-to solution, right?
I'm going to speak first because Alina is the transplanter. So, I think that this used to be something that was very important, particularly in younger people. And I think that over time, its role is definitely diminishing. And I can't think of the last person that I sent through for an allogeneic stem cell transplant. I think it was like 8 to 10 years ago. And I think that we're still trying to work out where that still fits in our algorithm. So we used to sort of say, well, if you're on a BTK inhibitor and you had a very complex scrambled genome in your CLL cells, then you should be aiming to move towards an allogeneic stem cell transplant. I think with so many different lines of options of treatment now, I think it's falling further and further down in our thinking. And now Alina can give you the indications for how we use it today.
Yeah, it's a great question. And for those who don't know, a bone marrow transplant is a transplant of your blood stem cells And when it comes from a different person, it's called an allogeneic stem cell transplant, which is what Dr. Scott is referring to. And that's what we would do for CLL if we were going to do a transplant. There's another kind of transplant where the cells actually come from yourself. We use that in other kinds of lymphoma. But for an allogeneic stem cell transplant, the reason we don't do it often is because it has a lot of risk. It's more risky than CAR T cell therapy that I discussed before. People can die of allogeneic transplants. So we used to only do it when there was really nothing else. And that has changed. It used to be quicker that we get to that point where there was nothing else, especially for people with deletion 17p. But now, even with deletion 17p, we have lots of options. So exactly what you said. Transplant is falling further down, but it really depends on also what drugs are available and access. So in different countries where they might not have access to a lot of these novel drugs, they are still using allogeneic stem cell transplant. But we're very fortunate here that, the role has been becoming less and less. The one place we still do consider it is in select rare situations with Richter's transformation. Sometimes it is still done. That's probably the last kind of patients that I've had go for an allo transplant.
Like a young person who's not having sustained responses to their therapies, and you're worried they're in their 50s and you're running out of things quickly. But they're hard, it's hard, you need disease control in those situations, and you're balancing the real serious risks of the allo transplant with the potential benefits. So it's shrinking, but there's still a role.
Okay, great. Why is CLL not curable while some other cancers are? We're giving you the easy questions,
Notice how in my talk I said CLL is incurable with current therapies. Notice how I said that. Notice, I showed you a few slides showing, giving you a sense of the complexity of CLL, giving you a sense that I had a slide with all that list of mutations. And I also had a slide showing the microenvironment and showing how the microenvironment plays such a huge role. So, we would all love a curative treatment for CLL, but you can imagine that it's not so simple as combining all of these drugs together and throwing them. It's going to take more than what we have. What I don't know, but it's a lot more complicated than what we would like.
How could you tell you have a cure? I mean, I'm in remission. 8 years, touch wood. Am I cured? Am I not cured? I don't know. Will I be cured after 10, 12, 13?
I think that I'm going to answer the first part first, and then I'm going to answer the second part second. So the first part is that what we've learned from lymphoma is that we're very good at curing lymphoma where the cells are multiplying very quickly. And that's because the chemotherapy and our other drugs work very well at pushing cells off a cliff when they're already dividing, and we just give them a little push. What we struggle with is cells that are actually sitting there not doing anything, what we call quiescent cells, because those cells are just sitting there, they're not doing anything, and then over time they may become activated. And in CLL and in other slow-growing lymphoid cancers, we think that there's a population that sits there that's very hard to target with our different treatments because they're sitting there doing nothing. So I think that that's probably why, at the moment, we can't cure CLL. Now, the second part is what we like to call a functional cure. So that means that you're in a state where, during your lifetime, you'll never require further treatment. So we can't say that there's no cancer in the body, but we can say that you haven't required treatment for that over time. And I think that as time goes on, we're pushing more and more people into that state, particularly with our treatments that are getting people down to below measurable residual disease. And I think that it's going to take quite a long time to work out how many people are actually sitting in that state, because our treatments are becoming extremely effective.
Somebody else wants to?
Yeah, I think there's some really exciting kind of trials and strategies that are now trying to think about, and sort of why you said not curable yet, because there are thoughts and ideas about this. And one of them is with the more cell therapies. So CAR T therapy, And then bispecific antibodies, I didn't really talk about too much, but there's now trials looking at after someone's finished treatment, they're basically in a remission. Now adding on a bispecific antibody to even get that remission even lower. And the whole goal here is to see, could we actually cure it, meaning get that remission as deep as possible and that it stays in that state forever. That's what a cure would be. And so there is a lot of exciting research looking at this, but still at the moment, as we've said, it's not considered curable.
That being said, so I agree. So to say that somebody has been cured, you need time. Like you need a lot of years. And so, something we talk in the doctor world a lot is, we have data for FCR, and there's a few experiences of patients who received FCR, especially patients with a mutated IGHV, and you follow these patients for 10, 15, 20 years, and a proportion of them, their CLL is nowhere to be found. Are they cured? We hope so, but we don't know. So I do think we cure a proportion of our patients with CLL where there's a perfect lock and key, but I just wish we did more.
So it's something we can hope that it'll happen to us, essentially. Well, great. It's noon. It's time for lunch. Thank you very much for the questioners, and thank you for the panel. It's a very interesting panel. So we're back here at 1 o'clock.
Before we go,
Dr.
is it
Scott's
okay if I
presence.
can ask a question from here?
From where?
I'm right here. Oh, I'm right here.
Okay, go ahead.
Yeah. So, as someone who is a DLBCL, CNS, and BMT autologous survivor, I wanted to ask, do you think that these novel drugs or therapies that are working for CLL, that are working for SLL, do you think that they can be transitioned over into these other lymphomas? And if so, why do you think that BMT is still the thing that's working for other lymphomas? And also one other thing that I want to add, I'm so sorry. It's just that I wanted to say that for someone that's a young patient with cancer, who survived cancer, not only did I experience a lot of pain, but there were a lot of kind of gaps in understanding what BMT was up until when I finished getting it. And one of those things was no one talked to me about fertility. No one told me about what happens if you don't donate your eggs, or not donate, you don't keep your eggs. And I understand that's probably because my situation was so different, where I had to get treatment right away. And by right away, I mean I was admitted to the hospital and was given chemotherapy 2 days later. So they had to order it pretty fast for me, or with CNS lymphoma, you tend to die within 3 months. That's like the average is what they've said. But again, those were my questions. I'm so sorry. Thank you.
Does anybody want to?
I can start. So thank you for sharing. And I think you bring up a really good point about young patients. And I'll get to your points, but I just want to say, so for CLL, as we heard, the average age is older, but there is recognition of the younger patients that are being diagnosed, and that there are gaps in care for younger patients. And it's across all lymphomas, but in particularly CLL, because the majority of patients are older. So the younger patients, there's actually been sort of a renewed focus on trying to address some of the gaps that are seen in the care for younger patients. Fertility is a big one. And it's not something we often thought about with CLL care because most patients were older. But now, as there's the recognition of younger patients, we do need to keep these things more on the forefront. Having been a transplanter, I know what it's like in that kind of situation that you're describing, where things move very fast, and we really want to have those conversations about fertility with everybody, and so that should be on the forefront for all of us. In terms of the drugs being used for other lymphomas, maybe I'll pass that on to my other colleagues as well, because that's a great question, and I absolutely think all of the things that we've talked about and the themes we've talked about today are definitely applicable to other lymphomas.
So I can talk about the drug piece. So some of the drugs that are being used in CLL were actually developed and tested first in diffuse large B-cell lymphoma. So the BTK inhibitors were identified, or the BTK enzyme was identified in, I believe it was in Lou Stout's lab, and he was involved in a lot of the development of BTK inhibitors through Pharmacyclics, who first developed it. So these drugs are now making their way into regimens for diffuse large B-cell lymphoma. Venetoclax and the BCL2 inhibitors have been trialed and weren't nearly as successful as we had hoped in that disease. But now we're working out that diffuse large B-cell lymphoma, which is the most common aggressive lymphoma, is now made up probably of 7 different subtypes that have different wiring in the malignant cells that we're now trying to attack with different agents. So those trials have either been done or they're being planned at the moment to sort of really sort of say, if you have this type of DLBCL, you should, or we should be trying this particular recipe which attacks that hard wiring. In CLL, we're more, a lot of the time we're actually attacking biology that's just part of the cell and isn't actually, there aren't mutations that have led to them being dependent on that. Whereas in DLBCL, a lot of these hard wiring things that we're attacking are actually triggered by mutations, which for some reason makes them less sensitive to these very excellent drugs.
Okay, thank you very much. And time for lunch, and back here at 1 o'clock, please. And thank you, and let's have some applause for our panel.